So good afternoon, everyone. We'll just give 2-3 more minutes for more participants to join, and we'll start off the session. Is that all right, Archana ma'am and Kritika ma'am?
Yeah, sure. We'll wait for another minute or two.
Yeah, sure.
Yeah, thank you. Kritika ma'am, the others faculty sir is going to join, or so we'll be late.
As I said, he's out of town, so he's trying to join from the mobile now. He was not able to connect through laptop. I just contacted him.
Oh, okay. Thank you. Thank you.
In 2 minutes, he'll be here.
Yeah, sure. Kritika ma'am, looks like
Could
sir
we
has
start?
joined. Can we just do a voice test if you don't mind with sir too? 1 second before we start off.
Hi, good afternoon. This is Dr. Leslie. Sorry for not able to connect earlier.
Thank you, sir. Good afternoon. Just wanted to do a quick audio test. Thank you so much. You're audible.
Right. Thank you.
Archana ma'am, over to you.
Should we start? Yeah. Okay.
Yes.
So a very good afternoon to all of you, and I extend a very warm welcome to all the respected senior faculty and my dear pediatricians on this virtual platform for today's session. I am Dr. Archana Iyengar, a pediatric palliative care consultant working for Hyderabad Pain Relief and Palliative Care Society in Hyderabad. So today's topic, ethical-based discussion making and advanced care planning, is very important, especially in the present era of healthcare, for both the pediatric intensivists, the neonatologists, and the palliative care physicians. For today's topic, we have 3 eminent speakers with decades of teaching and clinical experience: Professor Leslie Lewis, Dr. Manjari Digge, and Dr. Kritika Rao. Being an alumni of KMC Manipal myself, it's a great privilege for me to introduce Professor Dr. Leslie Lewis, who is a very well-known figure in the national platform, both in pediatrics and neonatology. He is the professor and HOD of pediatrics and neonatology in KMC Manipal. And I was lucky enough to have been guided by him in the last few months of my post-graduation when Sir had joined the department in Manipal. Sir, my regards to you. Dr. Manjari Digge is a senior pediatric palliative care consultant, currently working for the Ministry of Health in Kuwait. And a warm welcome to you, ma'am. We also have Dr. Kritika Rao, who is an assistant professor also in KMC Manipal, a lead pediatric palliative care services from the Department of Palliative Medicine in Manipal here for this session today. Welcome, Dr. Kritika. Before we start the session, a few Zoom etiquettes that all of you could kindly follow. Please position your video camera appropriately. Please unmute only when you would like to speak. Please type your questions in the chat box and they will be answered by the faculty in the question and answer session. There'll be a post test that will be shared with a recorded YouTube link after the session. Over to Professor Dr. Leslie, please. Thank you, sir.
Archana, thank you very much for introducing, and quite long time. This is, I think, Dr. Kritika will start with Dr. Manjari, and then I'll take over. Slight changes are there in the presentations.
Thank you, Dr. Archana Iyengar, madam, and good afternoon, everybody. A warm welcome. And as discussed today, this is just a gist of an overview of the talk that we will have, where we will discuss about ethics and the principles, talk about goals of care and what are the steps involved in planning and advanced care planning, and how do you communicate these goals of care and when a decision has been made. So the first part is going to be taken by Dr. Manjari Digge. Madam, please take it forward.
Thank you, Kritika. So I'm going to start off by just, enumerating the very basic principles of medical ethics and then really hand it over to Dr. Leslie and Dr. Kritika to deep dive into the discussion. So I've been working in Kuwait in pediatric palliative care for most part of the last 10 years. I did spend 2 years in Pune at Cipla's palliative care and research center, but what I want to mention is that, the medical legal environment in Kuwait is so different from India that it just might be, something to discuss as we go further. So in Kuwait, we are obliged by law to resuscitate every single person, whether it's a newborn baby who may be at the fringes of, life, or whether it is a person who's 95 years old with multi-organ problems. So given that do not resuscitate or allow natural death is status quo in this country, it becomes extremely tricky to do sometimes what is in the best interest of the child and the family. And most of it really is around the obligation to continue futile treatments. And I think that leads to a lot of moral distress. I'm just starting off the talk with this because it is so starkly different to how things are in India. I think India is much more progressive than how things are in Kuwait. And, we could talk a little bit more just to contrast and compare if that's useful for learning. Next slide. Thanks. Kritika, thank you. So I'm sure everyone is familiar with this. We've heard this in medical school. So what are the 4 basic fundamental ethical principles? It's autonomy, that means the right to self-determination. Non-maleficence, which means that any of the treatments that we offer should not primarily harm the patient. Beneficence, which is essentially our ability to do good for the patient. And justice, which speaks to fairness. Next slide, please. So autonomy really is centered around allowing patients to make informed choices regarding their care. Our duty here is to facilitate this process by making sure that patients are well informed and that they are free of conditions such as fear, pain, or mental conditions which may impact their decision-making capacity. So it's our role to do the best possible here. Now that might seem all very well and simple, but we care for patients who are too young, who are babies, who may be cognitively abnormal, or simply, because they are younger patients, the cognitive stage may not be appropriate for full decision making. Next slide, please. So now to make a truly autonomous decision, a patient should be able to demonstrate understanding of the situation as well as the implications of their decisions. So what does it mean to, for a child with spinomuscular atrophy type 1 at the age of 3 years who's not really showing any benefit with current treatments to be put on a tracheostomy and ventilator? This child could potentially live for years, maybe even a decade, with a very questionable quality of life. What is a child's understanding at the age of 3 years, an SMA type 1? It's hard to tell, and probably this child is never going to be the decision maker. The ability to be autonomous also is based on ability to communicate. And I know Kritika and Dr. Leslie will be deep diving into this. As I said, these are some of the factors that affect the decision making among children. And one of the things I just want to highlight is the authority of adults. So whether they are adults as in parents, and often children will undergo a lot of treatments because they do not want to displease or hurt their parents. And they may never say anything about it. Authority of the physicians and allied health staff. Maybe they don't want to displease any of us because we suggested a treatment and they just want to, do as we are saying. And then I think the society at large, which does it always think in the best interest of the child? So indeed, speaking to the example of the SMA type 1, I have a boy who's 8 years old who's received several doses of nusinersen with no benefit, who remains hospitalized for most of his life on a tracheostomy and ventilator. So authority of adults in the society and the ones who are supposed to act in their best interest at large. Next slide, please. Next slide, please. Yeah. So levels of decision making, the child has a right minimum to be informed, to be consulted, have their views taken into account in decision making, and finally being fully autonomous, being respected as the main decision maker. Now, going from 1 to 4, these are steps that indicate increasing autonomy in decision making, and these obviously would be affected by a number of factors. Next slide, please. Coming to the principles of maleficence and non-maleficence and beneficence, we basically have to, offer treatments that provide net benefit to the patient. We are aware that every single treatment we offer has potential risks as well as benefits. The overall aim of the treatment must be to produce net benefit over harm. I think that's quite clear. It sounds simple, but often it is tricky, isn't it? Some of the most challenging issues, obviously, in pediatric palliative care are around decision-making at the end of life, around life-sustaining treatment. Next slide, please. Next slide, please. So the point to remember here is that even if patients choose or families choose, or we feel that it is futile not for patients to have further escalation of care at the end of life or further life-sustaining interventions, it does never mean that, care is withdrawn, that there is nothing more to offer. That's absolutely the area where pediatric palliative care has a lot to offer. And that often looks like adequate symptom management, whether it is pain, whether it is delirium, whether it is other symptoms, nausea, vomiting, feeding, so on. It also involves giving emotional and spiritual support to the child, no matter what the age or stage, as well as the family. So fundamentally, whether or not a child can be restored to health, there is an absolute duty to comfort and to cherish the child and to prevent pain and suffering. And this is fundamental to every one of us that cares for children, whether we are nurses, doctors, speech and language pathologists, physiotherapists, or anything else. Next slide, please. Justice basically is the principle of fairness, that we have a moral obligation to act on the basis of fair adjudication between competing claims. That is what justice is about. So it might be the fair distribution of resources, who gets access to the IVIG when you have 3 patients with Guillain-Barré who equally cannot afford it. The respect for people's rights, which is rights-based. What is the right of the child? What is the right of the parent? And the respect for the law. which is the legal justice. And coming to this point in Kuwait, as I started out, because we have a legal obligation to offer all active treatment to all patients, irrespective of the outcomes, that really becomes tricky. Next slide, please. I'm just going to bring you a line from what is considered to be a landmark article that came out in the New England Journal of Medicine in 1982, where Eric Cassell says that the relief of suffering and the cure of disease must be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering in itself. I invite all of you to reflect on this, maybe later on, and think about it in your day-to-day practice. Next slide, please. I know I had a picture of some patients, or maybe I took it out, but I just want all of us to remember that we are entrusted with the responsibility of caring for individuals in society who are perhaps the most vulnerable and the ones that have the least voice. And I think it's a moral imperative that we do it well. Thank you for your attention. Over to Dr. Leslie.
Yeah, thank you, Dr. Manjari, for starting up the platform for a discussion. And as you mentioned, I think everything in your country, you people resuscitate, including newborns, where a question of viability versus 95-year-old adults. India is changing, and possibly most of the hospitals are presently trying to implement palliative care services, but still at the adult level, pediatric age group yet to take a momentum, and possibly in future, as many students are taking up these courses, we will be able to take up this implementation of the palliative care. Now, since a lot of students are there on this platform, I just want to brief them up. The burden of a palliative care in pediatrics is going up, and approximate in the year 2017, the what was mentioned is about 7% of the pediatric population may require palliative care. Now, what are these cases, or what are these children require the palliative care? To name few, the children with HIV infection, as they having a life-threatening illness, a premature babies with complications, the birth injuries, birth trauma, the congenital anomalies where the brain function being impaired, the injuries, and the malignancies. So these are a good number of children starting from pediatric age group to an adolescent requires the palliative care. Now, what is a good decision, and how does the good decision impact on child care? To reflect on this, basically a good decision where the parents, families, and physicians are coming in one decision for the better prognosis of that particular child. The poor decision can impact a child with life-limiting or life-threatening illness. It can affect the family, or could be a significant burden to the economic of the family as well as the health infrastructure. Change the slide, Kritika. So this is a one case scenario. I want the answer from few of the participants. So looking into the baby, can you tell me, anybody can unmute and one or two, or can put into the chat box, what is the diagnosis? Basically, this is a term baby referred to us from Bangalore for hydrops fetalis, non-consanguineous parents, and everything, antenatal screens, including scans, were normal at Bangalore. Anyone have an answer? Kritika, they have a chance to unmute and answer.
Yeah, they can unmute as well as chat, and I don't see anything come up yet.
So anyone want to answer any spot diagnosis?
Chromosomal anomaly.
Somebody's mentioned chromosomal anomaly. Can you precisely tell us what chromosomal anomaly? Salvator. Okay. Go ahead. Anyone? Edward, Turner, Potters. First rule out Downs. I think that's the right answer. So all of you mentioned many spot diagnosis, but this baby is the Down syndrome. Basically, this baby presented to us with a hydrops fetalis, and the parents thought they can be managed easily at Manipal, so they were brought down. But they didn't know that even though after evaluation, including the antenatal scans, the Down syndrome was not picked up. The family was, when we discussed with the family, if you look into the family, the 3 siblings from the maternal side had already mental retardation. One was mother's brother. He was about 45 years old, mentally retarded. And 2 other siblings, that is the mother's sister's 2 siblings were mentally retarded. The parents were very hopeful, thinking that something would be done for treatment of a hydrops fetalis. So treating the hydrops fetalis nowadays is not a difficult question, but here it is a non-immune hydrops. Usually non-immune hydrops, the complications are much higher than the immune hydrops. Immune hydrops, basically when mother is Rh negative, babies Rh positive we come across, and easy to treat. So the look of the baby itself as a delivered has given a clue that this baby has got a Down syndrome. So when we discussed with the parents, they were very sad. They didn't know how to proceed. And yes, this hydrops can be antenatally, the antenatally can be picked up, yes. But here it was not picked up because the last month scans were not done. They traveled from Bangalore to Manipal, native place of the mother, for delivery. So what do you think? Anyone can answer how you can counsel this family? Now you have a Down syndrome, one side. The second side, the hydrops fetalis is there. And the parents are already worried because there are 3 siblings, or 3 maternal side relatives are mentally retarded. Every parents want their child to be normal as much as possible. Anyone can answer how to counsel this? To treat or not to treat? First question.
See, it is life, it has to be respected. So
Okay.
you can never say that you cannot treat.
Okay.
Only way is you have to sit down in a good environment, basically, and sit with the team, all the family members and physician, telling in the detail about the future outcome, and also explaining to some financial help can be given with the help of some waivers from the hospital once they are asking for it.
Okay.
And,
Excellent. Excellent. The answer was excellent. Is there any other answer? Now the other side, poor outcome is explained to the parents. Yes, poor outcome is explained. My question is, should we treat this child? You already mentioned, correct. The problem is that mother's side, already 3 siblings are there, 3 children, 3 affected family members are there with mental retarded. The obvious the question is whether my child is normal. And we told, yes, this has going to have a problems. And the next moment, they decided to withdraw the support for the baby. So how to go about this? Anyone?
Early intervention.
So go ahead with the parents' decision.
actually counseling, nothing else. And once
We did 3 days continuous counseling. We did. from the time of delivery till the end, we did the counseling. In fact, we shown there are a good number of Down syndrome doing very good. In fact, we have few of them are in the campus. They are doing very good in terms of they're good in music. They're good in artists. Shown them incident. We have shown them. I think all of you know that there's a Red Fox organization, or Red Fox hotels in chain of hotels. And they also employ the Down syndrome or those are mentally retarded people as their the service people, the employees in their organization. Shown them this nothing is bad, so still can go ahead with the treatment. Still they didn't agree. Yeah, can go to the next slide. The next thing. So there's something called as the hospital palliative care services. That is called as Blue Maple in our hospital. And I think Dr. Kritika will highlight on that at later stage. And then it is not only it is a palliative care team also involved in counseling this parents, but ultimately the parents has taken a decision to take this baby against the medical advice. So the shared decision making is a well-established component of a patient care. Here, both parents share information and take steps to build consensus about the preferred treatment and reach an agreement on the treatment. So it is basically child, the parents, and the physician. And there are steps involved in a shared decision making. First is identify the ethical problem. And if you see here, the ethical problem here is a child with a Down syndrome and possibility of the poor mental functions. So try to collect the information. We collected the information. We know that this baby also had hydrops vitalis, which is also need to be treated simultaneously. And then we need to counsel the parents also further ongoing treatment. We given the facts to the parents and give them options. But here we had options: sustaining the life, that is the hydrops vitalis. Baby was breathing well, no ventilation was required. The baby had a fluid in the lungs, there is a pleural effusion which we have drained. Baby had ascites. The albumin levels were on the lower side, so baby required some amount of albumin infusion. And these are the treatment options we are given in addition to continuing the care. And then apply the ethical options or the practices or options to the parents, which we did. And then the final decision. And the final decision, as I mentioned, the parents has taken a decision not to continue with the treatment. Next slide. So this is what is called as the beginning of life. What are the ethical issues we come across? The end of life in a pediatric population. What are the ethical issues we come across? We know that viability period is anything beyond 24 weeks of gestation. In fact, the NRP 2020 guidelines says 23 weeks and gestation and above 500 grams. But we still are getting babies being delivered at 23 weeks of gestation and babies having a respiratory efforts, good heart rates. And what to do that group of babies? We still don't have a correct answer at this stage. So involving the mother, yes, maximally in the discussion, as well as the father and the most close relatives. And we know that a lot of issues are uncertain. Here, example, we know that this is a trisomy 21 with the hydrops vitalis. Our first concern is to treat the hydrops vitalis and means simultaneously to engage the parents so that they are able to take care of the baby in a long term. So what is the end of life? Sometimes the treatment are futile. Again, there's less uncertain compared to the beginning of life. We are more certain that the outcomes are bad here. So we have to again involve the child as well as the parents in a decision making. Here again, we have something called as a competence, where a child giving a consent. So what do you think? A child can be given a consent for a continuation of treatment, specifically the child is little older and in a state of able to give a consent. What is your, what do you think? Can a child give a consent for a continuation of treatment or stoppage of treatment? Somebody has mentioned more than 12 years. Yes, they can give the verbal consent. In fact, they should be a part of a discussion, specifically if a child can understand the disease, understand the implication of the disease, understand what the treatment options are available and what is the outcome. Definitely, the child can be part of a informed consent. So when it comes to the decision-making capacity also, it is a need to have a necessary cognitive and developmental skills. That's why it is a 12 years and beyond is the informed consent, and should be graded and varied according to the age. The more, anything above 18, the child or anybody, the adolescent can give a consent. But as of now, I'm aware of that 12 years and beyond. Maybe Kritika also can highlight later in your discussion what is the right age, and the medical connotation, and will definitely help us to take a decision, but child being involved in the decision-making capacity. Next slide. So this is little busy slide. I would ask you to concentrate on the left side, the beneficence versus the non-maleficence, which is already Dr. Manjari has already discussed. And what are the medical beneficence? We know that certain diagnosis or prognosis have a good outcome. Example here, giving the example, trisomy 21 is not bad. In fact, I would say that is the best the chromosomal anomalies can having a good outcome. Reversibility, yes, definitely in this condition, only the hydrops, the initial condition could be reversible, can treat that one, but trisomy 21 or any chromosomal anomaly, we cannot reverse. But a child suffering from malignancy, suffering from other diseases, they may be options of reversibility is there. Success probabilities, yes, limited in certain things. Goals of treatment we're going to cover up subsequently, and what are the alternatives and harm avoidance. Now look into the lower down on the right side. There is a blue color, the justice and autonomy. The family concerns are important. Family is always should be there in all decision making. Specifically, mother should be there in all decision making from the time of concept, from the time of the beginning of life till the end of life. But in our community or in our India, where we rarely involve the mother in decision making unless she's educated. So I think that concept has to stop. The mother is the pillar, and she should take a major decision for her child, and then maybe father and maybe the close relatives. And sometimes the religious decision also affect in decision making. If the parents are not in a state to make a decision, involve the local social leaders, the religious leader, so that try to convince them. As all of you discussed this case very well, maybe next step we should have done involving the social leaders, convincing the parents or the religious leader, and then we should have gone further. As of now, we don't have a legal authorities involving, and we do not have in hospital legal services to take such decisions. Conflict of interest always are there, and this should not be a research or academic interest. Next slide. So this is a very famous protocol called as Brunichin protocol for foregoing life-sustaining treatment, specifically for preterm babies. Here, a very basic things is the infant or neonate must have a certain diagnosis or prognosis. Example, it could be an infant or neonate with a spinomuscular atrophy. He or she must have hopeless or unbearable suffering. Nowadays, even spinomuscular atrophy, there's a treatment options are available on experimental basis, and some of the places the neurologists, pediatric neurologists are offering treatment. And here next is criteria 1, that is the diagnosis certain. And second thing is the unbearable suffering must have confirmed by at least one independent doctor. And both parents must give a informed consent. And this procedure must be carried out in accordance with the acceptable medical standards. This is basically for the withdrawal of a support in a neonate or infant. And this should be the Groningen protocol is followed. If we can also say that this could be a euthanasia guidelines for a neonate or infant or children we need to follow up. Next slides. Next slide. Kritika, can you change? Yeah, sorry. Okay. So not before the slides, just extend this. Sorry. Yeah. So this is the United Kingdom, the legal frame of law where professional duty care, the benefit versus the harm, a child's best interest, and the preserving the right to self-determination. In the meantime, the respect for the children's right, for a child's freedom to seek or receive the information, and right to express view and due importance to view as per the child's maturity. So as of now, we don't have this kind of practice are available in our country. Next slide. So this is where the situation in which is what appropriate or when to limit the treatment. There are 4 conditions called as there's no meaningful life situation. Example, this could be a child with a severe perinatal asphyxia, ventilator dependent, and refractory seizures. And you know that there is no meaningful life. The second thing is a no chance situation where there is expectation of imminent death despite aggressive treatment. Example, I would give here some of those congenital heart diseases, specifically hypoplastic left heart syndrome. We know that there are surgical options are available, and surgical options are not available everywhere. Second thing, the surgical options in hypoplastic left heart syndrome are not a fruit bearing. Third is there is no purpose situation where there is significant decrease in quality of life despite potentially extended survival. I would give an example here. We had earlier the bilirubin encephalopathy, but we cannot terminate here. They live with the complications. So there definitely some of the interventions can be done even though there is no the purpose. And the fourth one is unbearable situation where there is a phase of a progressive illness and further treatment is more than impossible. Example could be a child with the advancing stage of the HIV infection, the immunosuppression, along with the malnutrition, and the child is getting into a recurrent respiratory infection, and know that this child's survival is limited. Or a child in the initial phase of a treatment of a complicated the leukemia treatment, and you know that prognosis is bad. You know that you are definitely just giving a treatment that's not going to give any kind of a help. So these are basically classified into limited quantity of life, that's imminent death versus inevitable demise, versus a limited quality of life where the child has the absence of ability to derive a benefit of treatment. It could be a burden of illness or burden of treatment. And here the informed and competent refusal, where the parents are taking a decision sometimes to refuse the treatment for the children. Okay, so these are the few things where we can follow our guidelines related to our pediatric palliative services. Kritika, continue.
Thank you, Dr. Manjari Madam and Dr. Leslie Sir. That was a wonderful overview that we all have had learned about these ethical principles, but then how does it apply? And Sir just discussed one case, and then he brought up the Johnson's 4-box model of decision making, where he put up all of these ethical principles and all the medical, psychosocial, physical aspects together, and look at how it can help us with the decision making. So looking at that particular case itself, that there were a lot of discussions that needed to be done. Every time it came up that, we need to communicate, we need to talk to families, we need to explain them what is happening, what is going on, what could we anticipate in the future. And that is all about, which comes us to this topic about, discussing further goals of care. So this is again, not just the title of the slide, but also a question to everybody. When do you think should goals of care be discussed? Anybody would like to tell about, like, what are the time points that you feel that it should be discussed? You can type it in the chat box. At diagnosis, yes. Change in condition, very well. During repeat hospital admissions or at the diagnosis of a life-limiting disease, yes. It's a continuous process. Yes, very right. Very right. True. As early as possible. Correct. When complications happen. Okay, so most of you are very much sure about that. It has to be at the diagnosis, in the middle, in continuation, as the process changes throughout the time. Thank you for your response. So that brings me to talk about is that what are the various situations when goals of care change and where we need to identify those. So it is, as somebody pointed out, at the diagnosis or disease progression or spread, when there's a disease recurrence, especially where you see in malignancy, when serious complications occur, there are irreversible side effects of the treatment that you might be offering. At times, it will be difficult to control symptoms, refractory symptoms come in, or it could be a child who is capable enough to tell or voice over what they would want to have, their best care, or the parents make a choice for their child and they have their personal preferences, or in certain situations where it will be in terms of when we're trying to do the benefit versus burden rate. So there are these various time points, or I would say milestones along the disease trajectory, where we feel that we should have a goals of care discussion, or these are the times where goals of care should be evaluated with the family as a shared decision-making model. So the choice of goals of care that come across these different time points would be either that we are able to achieve a complete cure of whatever the problems is in terms of trying to cure the disease in itself. Say a child is diagnosed with leukemia, it's the initial presentation, it has a good cancer biology, we'll be able to give treatment for that. So you discuss at that point of time with the parents the outcomes of the treatment, what is the probability of survival after that, and you initiate treatment where there is. It could also be in terms of, at times, in certain illnesses, about prolongation of life or avoidance of a premature death. Goals of care would be also about, for some parents, would be only relief of the physical, psychological, or other distressing symptoms. Some parents may have dual goals of care, that, or rather not some, I would say every parent has that thing in mind, that they would always want the best for their child, but they also do not want their child to suffer it. So it is about trying to improve quality of life, relief of the distressing symptoms, but also see whether we can achieve cure or not. They will always be hanging on to the dual goals of care in most of the situations. There will be times when we might have to discuss end-of-life care when the child is worsening, despite the best medical management that you could provide at that point of time. And also in terms of support for the family that is required. Because in this, when we see in pediatric palliative care, we are not only looking at the child, we're looking at the whole family unit. Because if the child is suffering, along with that, the family themselves are also going through the suffering. So the challenges that can come up when we try to talk about making a choice of a particular goal of care, as I said, there will be multiple goals that they would be applying together. There would be fluctuation in and out of different goals of care, or there would be dual goals of care in the situation. Sometimes one of the parents might have a particular goal of care, like say the mother would say, I've seen my child suffering quite a lot. I don't want my child to suffer further. You do what is manageable at this point of time, which is going to keep him or her the most comfortable, but don't do something that will give him or her pain. Whereas the father may want to try everything that is available at hand, may even want to have resuscitation preferences documented, that they want to resuscitate the child, they want the child to be shifted to the ICU. We done a lot of aggressive intervention, so that can be contradictory goals. There would be no consensus with the family. So there are such challenges that can come up, or a precedence of one goal of care over another at any given point of time. So how do we understand what are the nuances in different stages, or when the primary goal of care is, say, curative? At that point of time, our entire impact or the aspect of care is over trying to eradicate the disease. We are looking at some acceptable adverse effects. We are okay with that coming in at the outset, that we are looking at the cure or the eradication of the disease. At that point of time, the parents will be like, we want to go all in. We want to do everything that is possible. It's an attitude is win and come out of this situation. We have to face the situation, brace the situation, or fight the disease is how they call it. Preferences for CPR would be present. At this point of time, the child is not a hospice candidate. And along with that, there will also be a secondary goal of care about trying to relieve of distress and also prevent any further distressing symptoms to come up. Family would need support. They would need to have some kind of a planning made for further in terms of if the situation worsens or if the situation stabilizes. At this point of time, we're not looking at bereavement support as such. But what if the goal changes to when we're looking at mainly palliative measures, or we're looking at life prolonging measures? Impact on the disease is about trying to see whether we can arrest progression. So in most of the diseases, there surges which you gave us the 4 categories, where we're talking about some child which will have a progressive illness along with additional significant degree of physical, psychosocial distresses also. In that point of time, the child may have a lot of physical issues come up because of the disease per se. You're trying with various disease modifying therapies, whether you arrest the progression of the disease. At this point of time as well, families have that fight attitude. They want to be trying everything possible so that they can, still try and see whether they can go back to winning over the disease. There again, there would be differences in terms of how parents choose resuscitation preferences at this point of time. Some of them might choose not to resuscitate. Some who are still in that win or fight attitude, they might still want to probably go with aggressive measures. Over the case, we might still have to have support put in place for the family, have measures put in place so that we are also balancing the act of not, adding more distress to the child and the family. When we move towards mainly symptomatic or palliative, when the goals shift into this particular zone, our main events that occur is you're trying all your best to avoid the complications. Even if the complications are present, you try to see what is correctable. You try to manage only which is correctable, and which cannot be, you explain, you have a plan put up in place for that, and you let them know that this is something that is not reversible. They may have at this point of time, over a period of time that you have had multiple discussions, come into acceptance about what is happening, what could likely happen in the future. They would have had multiple discussions with you where the preferences for the child to receive any aggressive interventions are already put in place. And here the primary goal now becomes comfort. They don't want any further distressing symptoms. The family just wants that the child is at most comfortable level. And continuing with this, you need to have, again, a contingency plan put in place that in terms of a crisis situation at home or in crisis situation in a hospital, how best would we try to make sure that the child and the family is at comfort? And they would, beyond after the death of the child, require bereavement support. So as we see that the goals of care shift, a lot of these aspects of care will also move through playing a role from primary towards moving towards the secondary aspect. So what are the goals of care planning components? When we talk about with such children with serious illness, main focus first would be about trying to see what are the disease management goals, whether it is some possible shift to complete treatment, whether we weigh in the risk of burden versus benefits, and trying to look at whether some disease modifying treatment should continue or we should try to stop that. And the main goal achieved at the end of this is about appropriate treatment decisions that has been taken. Then the next goal is about symptom management. The issues what are present at like pain or severe distressing, other physical symptoms are there. Old enough child would be really distressed, would be worried. They are in a hospital setting. Every child does not want to be locked up in a hospital cabin. They all want to go out and play or go attend school, mingle with their peers. They want to be at home with their siblings. They want to be in their environment, their comfortable environment, and they don't like being in the hospital setup. They will be probably going through some or the other distress, and at times it is very challenging because some of them suddenly might quieten down. They may not open up with us. So those subtle changes are to be addressed through. And our goal at this is trying to ensure that we have good physical and non-physical symptom control. The next issue, or the area that we should concentrate on, is communication. So the issues are about what is the parent, or if or the child is involved in the decision making, the knowledge of the disease prognosis and the diagnosis. What would they like to know? First, most important is about how much of an information does the parent want to know. At times, we insist on having both mother and father involved in the decision making. After coming in, the mother would be like, don't tell me much about it. That it has happened that I don't want to know. Let my husband decide. I cannot take it any further. I would not want to know what is happening. I would rather keep the decision making with the father of the child, and I would concentrate more on looking after the child. So it is important to respect what the parent or the other decision makers who are involved in the primary care of the child would want to know for it. And what is it of the meaning of the knowing of the knowledge that they have? Like, what do they understand by it? What is their value that they attribute to the knowledge that they have? So the goal you accomplish by addressing these issues and trying to have a complete, transparent communication of all the things related to the child and his or her illness. The next would come about decision making, and to look at who are the primary decision makers. They have the capacity to take this decision, and other surrogate decision making members. The next would be in terms of the practical goals, in terms of logistical issues regarding care, travel from hospital to home, or in terms of the child gets sick, then how can they get help in their local area, the infrastructure that they may have, whether they have the capacity at home or they need a service like a hospice center or a smaller nursing home where they can have the nursing support, the doctor support to be able to look after the child, and also the preferred place of care. A lot of times we assume that it might always be the hospital. It's because we're not always checked with the parents. Sometimes parents feel that if they're empowered well, they would be able to have better caregiving process done at home and within the social support that they have, their family support that they have. And the other further part is about anticipating that if it were that this child worsens or this child does not have a good prognosis, and in that crisis situation where we talk about resuscitation preferences, about putting on to life-sustaining treatment, these should be discussed in advance when you're sure about that this child along the disease trajectory may end up in the less than 6 months or less than 3 months time point of time, so that you have a contingency or a crisis plan put in place way ahead. And that is what is all about, anticipating that and putting that into picture for them, so that the parents are well prepared in advance that if it were to happen like this, who is the point of contact that they should be going to, what kind of care should the child receive, and how should we plan for that care at this point of time. So taking over these principles that we learned about ethics and a little bit about goals of care planning, this is another child that Dr. Zessi sir brought up, is a term infant with multiple contractures. This child after birth had severe feeding difficulties, needed to be put on feeding tubes, developed seizures during the NICU stay. And we've identified that this child would definitely have immediate and long-term sequelae in terms of this anomaly issues. But the parents wish to continue treatment at the hospital Their insurance, which was there, was denying further care for the child. It was not applicable for the child after the child was born in, and they did not have enough financial support also with them. So when this situation came up, as we had a care plan that was devised for this child, can you also help us, that we just discussed about the various components? What can you elicit out in this situation? What will be the issues that the child will have? So you think about various components, like I talked about disease management, communication, symptoms, decision making. So all of those issues, all of those components, what are the issues that you could think of happen? You want to put up something on the chat? Feeding problem, yes. So now the practical issues you identified is feeding issues, how to manage seizures, so physical issues. Talk about communication in terms of shared decision making, so anticipatory. You talked about aspirations in the further process, so multiple hospital admissions, right? Growth issues, absolutely right. The financial burden to look after this child. Bowel and bladder issues I see there. So developmental delay, activities of daily living be impaired. Okay. So far as term infant, long-term sequelae, contracture, poor growth. Yes, we have a fair amount of responses with all of you. Thank you so much for being active on the chat. Okay, we have someone say parents understand disease is not curable and will have multiple fractures, so needs to be handled gently. Yes, the psychological stress that the parents will go through while handling such a child. Very true. So when we looked up, we made a plan. So when we look up various issues like disease management, the long-term care needs that the child will have, in terms of even if the contractures are present, whether they would need to have some surgeries done so that they can try and if it is possible to correct it or not. Symptom management, because of persistent contractures, mobility is impaired, stiffness could come up, child can develop pain in the joint or the muscle. There could be psychosocial distress amongst the family members, mother and father who are caregiving. There's a financial burden that has come up, and that could add to the psychosocial distress. In communication, as you talk about the preparedness of the family in terms of the long-term sequelae of the event that can occur, the help that they require, they need the support for it that they require, and talk about what they can expect from what are their expectations, and really trying to make meaning around the realistic hope that we can bring up here as to what is likelihood possible for this child, whether the child is it possible for the child to have a normal a growth, or is it that the child will develop probably some developmental delayed milestones, may develop some intellectual disability? So there are these so many ifs and buts and uncertainties that can come up. In terms of decision makers, parents here being the main decision makers to be involved in all the discussions, the practical goals that you talked about, that in terms of dealing with the contractors, a lot of rehab need comes in, then the place of care where they want to look after the child, whether they have a facility nearby, at home, what is their social support that the family has. So importance is involved in about trying to look for the sources of support, mainly when you're trying to look at where children may have a long sequelae of events, may have a prolonged illness. And at that point of time is where parents need that support. Look, what is the family structure, individual family structure, a joint family structure. There are other members living nearby who might come for support. These are important to see what is the sources of support that the family has, and anticipatory goals in terms of what are the feeding issues, risk of aspiration that can come up, mobility issues, the contractures we are not able to surgically repair, child will continue to be dependent on the parents for life, and that will lead to other complications. So there is a whole lot of areas that needs to be addressed. A lot of times it happens that we have had some bits and pieces here done, but we don't talk about an advanced care plan. We don't talk about what to be done in a crisis situation. What is the best decision for this child when we weigh in the burdens and the benefits of all the possible treatment. So when we take this forward, it comes across about talking about how do we decide, how do we then communicate these goals. Ma'am, would you like to take the first few slides? Dr. Manjari, madam?
Yeah. What do you want me to do exactly? I'm sorry.
So we thought about here was about the framework for shared decision making and in the goals of care planning, where we talked about the decision making capacity for the child, the parent, and the medical doctors.
Yeah. So I think basically, I mean, it does all come around while we do follow the frameworks and so on. It is about, first of all, do no harm. But then we are faced with this problem of prognostic uncertainty. And then to add to that, the level of individual circumstances of every family. So if this was a patient in Kuwait, there would be no discussion around it. This child would be for all active interventions. But there is a clear-cut difference between the populations in this country. So the Kuwaiti population has access to all medical facilities free of cost, including treatment abroad. Whereas the expat population, which would be a significant majority, would have to pay out of pocket. So even though the law is the same for everyone, there is that clear dichotomy. So what is it in terms of feasibility of continuing the treatment? Is it going to devastate a family financially to such a point that they will no longer be able to care for this child at home? What does life really look like? Prolonged hospitalizations, repeated hospitalizations. What is the quality of the life of the child? So a lot of practical issues around the decision making. So I think in India, while we will be doing things that are in the best interest and based on medical, legal, and ethical frameworks, a lot of the decisions actually are made on the basis of, what is practically available. So I think that is how it is. I mean, we have to be really pragmatic within our circumstances. Kritika, do you want me to run through the slides?
Yeah, sure. I can just take it forward.
Yeah.
Yes. So, yeah, ma'am, carry on.
Yeah. So I think this is really a repetition of what we had, what you guys had discussed. So I think in summary, when we are offering any intervention to the family, it's, is it going to be an intervention that will cure the disease? If it's not going to cure the disease, will it prevent progression? And I think, it might be things more clearly seen in oncology care, where, say, chemotherapy is of palliative intent. It may prevent the progression and perhaps has a slim chance of cure. What will be the impact of the intervention on the child's quality of life? So, say, will giving aggressive chemotherapy result in severe debility, very serious risk of infection, and so on? Will the intervention improve the child's symptoms? Will it make things worse for the child? Because every significant treatment does come with significant side effects. And what will happen if that treatment is not offered at all? Will it foreshorten life? Will the quality of life deteriorate too badly? And fundamentally, how will the intervention change the outcome? Next slide. So again, to summarize, this is basically a collaborative process, and the voice of the child needs to be taken into account wherever possible. And if it is not the voice of the child, then the parents, and Dr. Leslie, as he said, the mother. Now, again, just to compare and contrast between India and Kuwait, here the decision maker is the father. The mother really doesn't have much say at all in the decision making. So it's a really tricky situation. And then what is the level of communication between the staff and the families? So that is foundation to the trust. And unless the families are really told. So that speaks to, I think, good communication skills and how essential it is to have those open, honest conversations with the family as early as possible at all those critical points in the disease trajectory that we discussed earlier. And even if something that the child or even the family says may not be entirely, we may not be able to do things as per what they are saying, at least the opportunity for them to have said their view, to be heard, I think that's incredibly important. So making patients and families heard. Next slide. The decision making of the family, in many ways the families are they are in a way power of attorneys for the child's hopes, wishes, because the parents we consider would be the ones who would know what is in the best interest of the child. And then again, of course, in India, there's the whole extended family, and what is their role? Is the grandmother dictating the decision making and so on? Next slide, please. The medical staff. So our duty, especially the senior physicians, our role is to make sure that we are not just offering treatment options, but really offering them our expertise and our experience in terms of what could be the best possible treatment. That we are discussing the benefits and the burdens of proportionality. And we are also aware of our own biases in the way we offer treatment. For example, just the last week, I had a fairly contentious discussion within my team around the care of a child who was 8 years old with Niemann-Pick disease type C, who was dying. She was dying from an aspiration pneumonia. She'd been extensively treated. She'd been in and out of ICU for a month, and she was clearly not getting better. The family clearly expressed a desire for, only comfort care and just for the child to be allowed to pass peacefully. Members within our own team had a very different view and felt that, it was the sanctity of life beyond, over and above everything else. So those are kind of team conflicts that do happen. And we really need to be able to sit together and be aware of our own, thought process and our own biases when we offer our opinions to families. The other members of the healthcare team, I think they are very critical sometimes, and especially nurses or physiotherapists that work closely with these patients and know patients in a kind of an intimate way that physicians shouldn't. They should really be encouraged to give their inputs. And as I said, with the case I gave, while it's unreasonable to expect a consensus in all cases, all staff should at least be felt that their voices have been heard. Next slide, please. I think this is not my slide. Kritika, do you want to take it?
Yeah, I was just about to. That's what Madam was talking about, the various aspects of decision making. And she brought up a lot of important things in terms of patient perspective, the family's perspective, and also from the medical team that is looking after. But before we've had these discussions around decision making as well, but when we want to try to communicate now, and we ourselves are sitting through and discussing about it, we should probably have some answers to the below questions before we go on to communicate it. One is, what is the reasonable thing for the patient or the family to hope for? What are the realistic goals that can come across in this particular case, particularly say the child that we discussed with hydrops fetalis, and then again later which way we saw the child with the multiple contractures. What should be there be a setting of limits as to what extent should we go up to, and beyond that is something that we should not go for because it may or may not benefit the child. Then in terms of what is the coherence or what is the link between the two, what is the trajectory of the goals that are going to be determined and the trajectory of the illness that the child has, versus also look at medical versus the non-medical goals in terms of what are the wishes of the parents, what are they feel that is appropriate for the child. They know the views, the preferences, as Madam pointed it out, what the child would have liked, or if it's in case it's an infant, before antenatally itself, parents would have had certain thoughts about how their child should be, what they would like to aim for their child to have, how all those things, and that all needs to be taken into account. And look at whether there is a consistency of goals amongst the family members involved. At times, even the child who is at the brink of adolescence, like 17, 18 years old, they're still seen by the pediatrician, and the parents are also the main important decision makers here. Is there a consistency of goals amongst both of them? We look at whether are they ready to discuss goals. Most important, we forget to check with them at what stage of grief are they in, whether they are in stage of whether they are open for us to have that communication with them or not. Look at whether when we pass on the information, are we able to balance the truth versus realistic hopes? Are we able to address the benefit versus burden of initiating some kind of a treatment or any aggressive intervention? And talk about the meaning of the various interventions and the non-intervention that phase that you could decide upon. Like what is feasible? Sometimes it happens that the parents are just asked that, we'll have to resuscitate the child, we'll have to put on the intubator, we'll have to put on the ventilator, we'll have to do CPR, otherwise the child will die. And at that point of time, parents are taken aback because when you put it out like that, they will feel that this is the only way that the child can survive, or this is the only way that care is possible, and there is no other way. And they might say yes to everything that we end up. So it's a very yes/no question always put up. It's never given as an information of what is best, what is not helpful, and what could be done at that point of time if they decide to not go very aggressive. So it's about trying to make sure that we see whether they've understood the meaning of what you're telling. And what about also is not abandoning the child, not abandoning the family if they make a certain care choice or care preference. So when it comes to the language of communication, a lot of times it has been done that, do you want to do everything? Do you want all interventions to be done? Do you want him to get all possible care? What encompasses all? That is important to elicit out very clearly and openly. Rather, we should talk about what will enable the patient to live a better, meaningful life with their illness for as long as possible. So talk about in terms of what is helpful, what is not helpful, what could help towards comfort, what could help towards meaningful survival, rather than what could be towards more harm and more suffering. Then there's also talk about, will you agree to discontinue care? When you say the term care, the parents are distraught. I mean, like care meaning everything stops, even whatever minimal support that the child would get in the hospital, everything stops, and they would be abandoned in one point of time. That is the fear that comes up, and a lot of times because of the fear of abandonment, they don't tell you what they really want, and they go by all the decisions what the doctors or the physician group or the healthcare team will take for. Rather, at that point of time, discussion should be more about trying to frame it up in such a way that the focus will be more on comfort and improving quality of life. So there are various these, the way we communicate, the way we talk is important about how the family will understand and take it through. Like this happened recently as well. We in our hospital we try to have as many times as possible a joint meeting. Whenever a palliative medicine consult is called for, it has to be with the primary physician, and we are part of that discussion. We never have separate discussions out. But at times it would have happened that in a hurry or because of lack of time, the primary team would have already discussed with the family, and they move, and we are just told, you please talk to them. We cannot come back, and this is what we have conveyed, and they have not agreed, but you can still try from your end. So I said, let me try and speak to them. Let me speak to the parents and check with them what is their understanding initially after what you have spoken. They were utter confused. They were just like, we were just given options, they were just thrown at us. We were not sure what will be the implications of if we take a certain direction and what could be possible, what could not be possible. So when we sat down, explained out everything in more detail in a language best understood by them, giving them the options of what is beneficial, what is harmful, taking them through that process and eventually coming to a decision what is going to help improve the child's quality of life. That is something that they at the end told that we were very confused when it was said earlier, but now when things are laid out so well and easily understandable, it helps us to make a decision faster and rather a better decision what they would have not otherwise not achieved for at this point of time. So to take this forward, when we talk about the 7 steps of communicating goals of care, it is about very important that we try to create a better setting. Standing in a hallway, out of a ward area, at the bedside is not the setting that we should. So a lot of times in our ward, in our regular day-to-day practice, there are these few cases that you might want to have discussions with. So you can better to have a time allotted in your OPD chamber or a separate room in the ward area where they can be seated. And more important is initially is to find out what they already know or they understand and how much would they want to know further to make certain decisions ahead. So it's like also trying to put in a thought process that we are here to discuss certain important things for the child. And we would first want to understand how much do you know so that I can accordingly guide you further with the information. And would you be comfortable to have this discussion right now? Or you want somebody else also as part of it and you're not ready for it to do it alone. So that's very important to focus because families look for sources of support. We've seen that in the Indian culture or rather in the entire Southeast Asian culture, there's the whole family comes in together to support them. Sometimes the parents are at home, but the father's siblings or the mother's siblings are in the hospital and looking after the discussions every day and relaying it back at home. So it's important to look at who are the decision makers here and who else should also be part of it. Next step would be about exploring what are they expecting and hoping for at this point of time, after you've understood what they want, what they know about it, and what they're hoping, looking about trying to make realistic goals, every time we have to have their emotions addressed. As because if we are not able to connect with them at that level, they may not really try to open up with us. They may not really tell us what really they have fears in their mind or what they are thinking through, and we'll not be able to get across to them and have that therapeutic alliance created with them to be able to have a better shared decision making. At the end of all of this, never leave without a plan. It's good to have a plan in place, or even if there may not be a plan, it could be about what could be next. Say, if you're waiting for a particular test, you're waiting for a particular consult from a super specialist that you've taken in, or you have a plan that today this is what is done. Let's see in 24 hours how the child is, and tomorrow we meet again at this particular time with everybody else who needs to be here. So this is like something that the parents can take back through, that they know you're available next at this point of time and what they should expect in the next 24 or 48 hours, whatever the time is decided, and then come back to you further about to know what is to be done. So it gives them time to go back, understand, process, think of what other options you would have talked about, and then come back to you with certain decisions as well. So when do these communication issues or when these goals of care change? It'll come as in times of cessation of disease modifying treatment. We talk about recap, about the benefit versus burden, talking about realistic hope. When we talk about the transition point in terms of where to always look sure that you're not abandoning. How can you provide a shared care or even at least have maintaining a continuity of care at another place? What are the scopes of services that can be possible and clarify the various myths and misconceptions if it were there to the parents? Next is about prognostication in terms of foreseeing what can happen, telling them about anticipatory issues, discussing the overall prognosis that a particular child may have, the disease at this point of time, where they are in the disease trajectory, and then making an understanding around it about or prognosticating the family around it. The anticipatory symptoms in terms of what to expect, what are the possible complications, what is realistically possible to achieve at that point of time, and have that contingency plan, or as I said, a crisis plan that they could have to hold on to in case of things were to go wrong. What is the steps that they should take so that they don't panic, they don't take any decisions in haste. They're very cool and then they know this has happened, this was already told, and this is what I'm supposed to do. Talking about advanced care planning is in terms of looking at places of care, putting those systems in place, as in the social support, whether the care would be at home or in a hospital with the help of a local physician. What are the goals of care in terms of medical goals of care, that what should be done and what should not be done. Non-medical in terms of what are the child's wishes, how they would like to be cared for, where they would like to be cared for, and along with who all should be there with them. The life-sustaining treatment choices, the preferences, asking it in the right way, talking about what are the various preferences that they can have at this point of time, whether it is about withholding for the escalation, not doing certain procedures, or look about that ethical considerations that can come up. So there is A lot of times we come across people saying that there's a legal gray zone, that there is nothing that has created a law for neonates or for pediatrics separately. Indian law or the articles in the Indian Penal Code and the Constitution and the recent Supreme Court judgment does not differentiate between a child and an adult. Every law is applicable to every living being here, human being that we are there. So it doesn't differentiate that this law is only applicable to adult, but you can't apply it to the child in picture. So it is always looked into various aspects. So there are these, I can share the information later. There is this Supreme Court judgment of January 2023. Previously as well, there were amendments made to the Article 21 and IPC section 76 to 79, where they have taken into account of all of these concern. And so it is not the term that is used about passive euthanasia or euthanasia is not what is there, because you're not actively doing something to kill, because they are going to die because of the progressive nature of the illness. What you are going to do is by trying to not prolong their suffering or not prolong that death phase. And that is important to keep in mind, because all of these decisions by the parent, the healthcare team is in the best interest of the child. Further, it about the specific situation. There could be certain challenging communication situations where denial, whatever you have done, said, family doesn't accept it. There's collusion, that is, the one of the parents is not telling the truth, the other says, mother is completely unaware, father knows everything, or both the parents don't know, but a third member of the family is aware of everything. And they're trying to shield the family from the information because it is only out of the love for that person. The family doesn't want the mother or the father to know so much. Either they will get very distressed or they'll not be able to take the news. So it's always good to delve deeper at this point of time and not try to directly abruptly go and break that collusion, but rather understand why the family is doing that, or in cases of denial, explore further as to what is going on through the parents. If conflict is there, one parent has a different decision, the other has something different, explore out. It's always, as one of you had pointed out, it's all about communication, communication, and communication. It's every time it's about trying to sit and talk to them and understand what exactly is going on, what are they thinking, what is their deep seated thoughts about it. And then talk about looking at terminal care is to give them a estimate of what could happen, what to expect, what are the meaning of these symptoms. A lot of times the child is gasping at end of life, is very restless at end of life. Family gets too distressed looking at that. When we try to explain them that this is the normal course of symptoms that is expected at end of life, and tell them what could be done to relieve of those symptoms, how they can participate to provide better care for their child and comfort, that will help them seek more acceptance to look at and provide a better care rather than get more and more distress at that point of time. And important is to have the immediate after that communication, being there and providing them the bereavement support to cope through with the loss, because you have been with the child throughout the entire trajectory of the illness. You know the child in and out, the preferences, plus as well as the time, the parents' preferences and their choices and how they have been. That therapeutic alliance helps you to provide a better bereavement care even after, for them to be able to cope through the loss of their child. So bringing it back to the situation, when we looked at a lot of aspects, a lot of concerns, a lot of issues around this. This case also had that we had to discuss about further goals, make a plan, because there was a long-term illness coming in. There were these things. So like when you look back at the goals of care planning, that talk about communicating with them, where Dr. Leslie sir also at the start said that with a child with hydrocephalus, it took us 3 to 4 days to be able to talk to them, give an understanding, and be able to make a choice later and withdraw any life-sustaining measures and provide only supportive care and comfort care. So based through this, we come across various issues. A lot of times, in practice, it happens is we fail to discuss their expectations. We end up offering very unwanted interventions like we should do this and everything, and then we realize there is nothing more can be done, and then we say there's nothing more. Now this is the last that is possible, and there's no benefit out of this. So then we have exhausted out of all those things which are not supposed to be initiated in the first place as well, because it was not going to help the child. A lot of times we are thinking problem oriented, that let's solve the problem now, let's think about it later, what can be done and what cannot be done. And about the languages that we use, sometimes a false sense of hope also. Like sometimes we try to say in numbers, say it is 20% better today, say it is 50% better. Families will hold on to that number. They will catch hold of that thing and they'll ask you, say, what is percentage today? How much better today? How much it's going to help by tomorrow? So they will want to have that kind of some word of hope from you that they can hold on to and be able to, take it up and then go ahead with it. And being excessively optimistic about the estimates of prognosis. Like I've had sometimes people come say that we were told it's just a matter of 3 to 4 months, but it's become 1 year now. And then you are caught because you don't know how to say or what to answer because somebody has given them a number and families, like child has braced through it, has moved beyond a year, moved beyond now that and is almost a year old or beyond that. Now what do we expect? So it's again a difficult situation that can occur. So why we think of it as difficult to discuss is because there's a lot of times a sense of hopelessness and helplessness that the families feel through. It is also from our side as well that we feel helpless at that point of time and we don't communicate or address these concerns at the right point of time. It's our own fear regarding the process of death and dying and how do we provide that care. Maybe the lack of time to prepare the family gradually or dealing with the expectations because they may be coming up with a lot of questions and it's become hard to during your daily practice or daily busy time that you may not be able to give each time that much amount of time for them. Facing the anger or the aggression. Sometimes we feel that it's better not to say certain things because they might really have a lot of emotions flare up or they might get very angry. Or our own need to reassure the patient and make them feel that everything is all right, we're all taking it under control. Or rather the whole thing about fear of destroying that hope, fear of destroying that hope that is being created, whether it is realistic or unrealistic, we don't know, but we just feel that let's not, break that hope that the parents have, let that hope be there and I still continue to do what. But that can create a lot of mistrust later, issues in terms of appropriate care that the child should receive, decision making at times point. Like, it could be that everything is done and then we are suddenly coming in, jumping in between, and one point of time telling about, okay, now things are done, nothing is going to help. Next is either child has a cardiac arrest, should we resuscitate, should we not? And it's a sudden decision being put on them out of nowhere, and they would not be able to take a decision at that point of time. They'll be really fearing for it and they'll not be able to understand. So with that, Manjari madam wanted to talk about this particular slide, and then after that, we're happy to take any questions.
Thanks, Kritika. So, credit to Google. These are not my pictures. This is just a reminder for all of us to remember who are our patients. These are the people who need us. These are the voices we need to be heard. And I think it's that moral imperative to do the best possible without doing harm for our patients. Thanks.
Thank you, everybody. Listening to the talk. We are happy to take on any questions if you have.
Ma'am, there
Thank
are
you
two
very
questions
much
in
for
the
elaborating in detail about palliative care principles, goals of care, and most of the things what we come in day-to-day practice, wherein multiple sessions of counseling is so important, and always it's important to offer what we can offer, to tell them about what we can offer rather than what we can't do at that point of time. I think we have a question. How should we go about legality and when legality and ethics clash? Dr. Manjari, would you like to take the question, please?
Right. I'm going to answer this question, but look, I'm going to do it from the point of view that I see on a day-to-day basis in my practice here, because it's so stark. So, for example, the child with Niemann-Pick disease that I mentioned earlier on in the talk, family wanted comfort care only. This was an expat family, so they were bearing the cost of all expenditure, which was tremendous. Versus our obligation to keep the child alive no matter what. So we did have a goals of care discussion, and the family repeatedly kept saying comfort care is all we want. We don't want you to prolong her life. Are you doing something that's keeping her alive? And I said to them, no, I'm not. And the mother points out, but you're giving her oxygen, aren't you? We were giving her oxygen through high flow nasal cannula. because that's how she was transferred from the PICU to my ward. But then we discussed further and we managed to send this child to pediatric hospice. There is a pediatric hospice in Kuwait, which is very beautiful. Again, it's a paradox. Why does this country have a hospice when they don't have clear-cut laws around end-of-life care? Anyway, so we send them there. The hospice has the ability to take a signature on a waiver that acute treatment is not provided here. So, you know, it's really, in a way, cutting corners, but doing what is in the best interest, in the hope that you will not break the law. So the child went there, had excellent comfort care at the end of life. She maintained her saturation on non-rebreathing mask and, you know, just that. Did not need the high flow cannula. Her symptoms were managed well with morphine and midazolam. And she passed away very peacefully. The family was happy. We were happy. I think here in Kuwait, the greatest fear for me is to stay out of jail while doing what the family and the child's best interests are. And often, you know, it is about perhaps being a little bit more pragmatic about how it could be done. So while all these discussions happen, they need to be documented in a particular way. Now, India, fortunately, is much more forward than this, and documentations would happen as they actually did. So verbatim, goals of care were discussed, the implications of the treatment and the implications of not offering that particular treatment were told to the family, and this is what the choices were. So I think, you know, I've given you a very stark contrast of a country that's fairly backward in the medico-legal arena. Maybe Kritika or Dr. Leslie, if you're still there, do you want to compare and contrast what would happen to my Niemann-Pick disease in India?
If that child was here in our hospital and whether in Indian setting, like I pointed out earlier as well, with regards to legal, when you talk about legalities, as I said, the Constitution, Article 21, the IPC codes, all of them talk about taking a decision where it is in the best interest of the child. And when you're doing it within the boundary of the laws, that you're not causing harm, you're not going to cause any more further suffering, and at the same time, you're looking at what is going to be best for that child at that point of time. And after having put into all of the ethical principles, if you take a decision to not escalate further care or even withdraw support and provide more comfort care for the child, it is still under the law that you're doing what is good for the child at that point of time. It is not that tomorrow we will be able, because our hospital, we have framed a similar guidelines around it called as the Blue Maple. I'm free to share the link of it in the chat in a while later, where you can see the document where there are certain criteria put up. How do you assert utility in certain situations, and what is the process that you follow to be able to document foregoing life-sustaining treatment, either withholding further escalation, or the child is already on supports, then to withdraw life-sustaining treatment.
Thank you, Dr. Kritika. I think it's always better and easier to withhold than withdraw life support, because incidentally today, before starting the session, we just did a compassionate extubation for a baby with congenital myopathy who was ventilated. So a lot of things that you had said was, I could relate to many of it, because since a week we have been counseling the extended family, and finally today they wanted the extubation to happen. So any other questions, please, from anybody else? You can either unmute yourself or type it in the chat.
Hi,
Can
हो
we,
खत्म हो रहा है क्लास चुप रहो शांत
Please go ahead. Yeah.
maybe euthanasia, if I can use that word, if we are withdrawing the support which are required for the sustaining of the life.
Ma'am, in euthanasia, the intent is to kill, wherein withholding support, the intent is not to kill, it is just to keep the baby comfortable. So we always explain to the parents that the medications that we give will neither prolong or shorten the life of the baby. It will just keep the baby comfortable with respect to either pain or respiratory distress or delirium or anything depending on the disease. So we make it clear that it is not euthanasia, because first time when we counsel them, then they express these things to the other family members, immediately that strikes to them first, and then we have to explain and tell them that it is very, very different from euthanasia. Dr. Manjari, would you like to add anything to that?
So unfortunately, this term passive euthanasia that has become mainstream in India because of the law and the way that things changed around advanced directives. I think it's a very misleading term. I would love to refer all of you to the textbook called The Introduction to Palliative Care by Dr. Robert Wycross, and look at the definition of euthanasia in that. So euthanasia, or a good death, is defined as an active intervention that is carried out with the explicit aim of ending a person's life in order to put them out of their suffering. So that is what euthanasia is. And again, the aim of euthanasia is beneficence, because after everything has been done and a patient has intractable symptoms or distress, anguish even, that is when euthanasia would be practiced. And there are certain countries around the world where it is allowed. Not in India, definitely not here in the Middle East. So, de-escalating or withdrawing futile treatment at the end of life is not euthanasia, because it's not done with the explicit intent of killing the patient to put them out of their suffering. It is done when there is disproportionate harm, burden, or there is no likelihood of achieving a result which may be qualitatively or quantitatively worthwhile for the patient. So essentially, this is treatment that is futile and burdensome. Say, okay, now speaking to this 8-year-old child with SMA who's been on long-term trach and vent in my ward. We've been caring for him for 3 years since my unit started. This boy is in what is called a locked-in state. So almost virtually no motor abilities, but has a significant level of cognition, is unable to communicate in any form. Family barely visits him. So the quality of life that this child is having is simply unbearable, right? And de-escalating care, or de-escalating, not de-escalating, but de-escalating the invasive treatment would not be, it's basically a futile intervention. So that is what we are taking away. That's not to say that we wouldn't care for the patient. We would continue to care for him in terms of comfort, making sure he's not in pain or in distress or breathless. Giving him the comfort of sound, touch, and all the other non-pharmacological things that basically bring comfort to this child. So I think the distinction is between futility and the definition of euthanasia that I just said before.
I agree with
Thank you,
your
Dr.
explanation.
Manjari.
Only thing, is there any kind of documentation? Because in the court of law, ultimately, what will save you is some kind of documentation. Nothing else can save you. So unnecessary hassle of going to the court, and these are all very issues when we are withdrawing the life supports, life care support for the child.
Kritika, do you want to answer that? So one very useful document is the Blue Maple document from Manipal, which was really, groundbreaking in terms of documentation. And then the laws that the Supreme Court rulings that came subsequently. But I think a better person to answer that is Kritika. Do you want to answer that one?
Yeah, madam. I had put up that document on the group, madam. So you can go through that. That also puts up the process and how initially who the teams are, who should be part of the decision making, who comes into documenting the futility, and then endorsement of that futility criteria, and then having a communication and documenting family communication, families' directives, what they want to go. And it also has a process at the end, which is also vetted by the recent judgment, that there has to be a secondary board which will ratify that this decision by the family and the healthcare team is in the best interest of the child. So this is like a whole process which is legally vetted. It is done by peer review with legal experts, as well as the legal team which was involved in the end of life care task force in India, who was part of this recent Supreme Court judgment. So she is one of the authors for this document. So you can go through that. That will give you a guidance of how you can try to, process that in your institution as well. And as well as the DNAR form and the various formats are available with the ICMR as well. They have come up with a recent paper where they have put up the documentation, what should be the document carry out, what all aspects that need to be, cleared through.
Thank you.
Most
Can I
welcome.
say something?
Thank you.
Hello?
Dr. Kritika.
Can I say something? Hello?
Sir, please go
Hello?
ahead, sir.
Yeah. See, actually, that euthanasia and then the other thing what we follow in palliative care is a doctrine of double effect. Basically, the difference is euthanasia, the goal is death in the end, primary goal, whereas in the doctrine of double effect, it is to relieve the patient from the symptoms and what all the side effects is taken as granted, and we don't mind about that. That is the difference between euthanasia and this palliative care. That's what it is.
Thank you, sir.
Any more questions?
please? Yeah.
We are at 4:40 now.
Yeah, I think should we wind up, ma'am, in case there are no questions?
Yes.
Yeah.
Yes, let's. And I think most importantly, the documents that Kritika has shared are really important, that everybody kind of is aware that they exist, and the fact that the things that are not legal in Kuwait.
Question.
Kindly unmute.
How do you cope? Hello? Hello?
Please
Yeah,
go
we can
ahead.
hear you.
Yeah, myself, Dr. Prashant. I have one question. It's not of, patient side, it's on the doctor side. Means how do you cope with all such losses and what I can say, you witness so much death. Sometimes it gets to you, okay? Because I work some in PICU and NICU. How do you cope? Doctors and staff, how they cope with these things?
Thank you for bringing this up, and it's incredibly important because we are now going into physician burnout territory. What I have practiced is, I've been a lead consultant on the teams for almost over a decade. So it kind of falls to the most senior person on the team to support the rest of the team. We would have certain rituals when a patient passed, which would be perhaps, taking maybe half an hour for the team to debrief. Maybe taking the team out of the hospital environment for that half an hour, maybe have a cup of coffee and talk about how people felt. If there is the ability of involving a psychosocial professional to do team debriefings or some kind of coping strategies, then that's incredibly important. So I think peer-to-peer support, acknowledging that the losses that we are facing professionally are affecting us as human beings, being there for each other, kind of having the ability to take a little bit of time off if someone's had a really rough day. So just basically around being kind, to one another. If it's possible to have a social worker, psychiatrist, or a psychologist who will do formal sessions for the group or individually, that would be wonderful as well. So thank you for bringing that up. And it's incredibly important that we have access to this.
Thank you, Dr. Manjari. I think all the whole team involved with the child needs to debrief, not only the doctors, but even the counselors and nurses, because everybody is involved towards the end of life care with the child. So debriefing sessions are really helpful so that we can again give our 100% justice to the next child once the end of life of one child is over. So,
and I would also like to add that, along with debriefing with the team, you also need to have some kind of self-care method that you do to be able to go back.
Yes.
And
because ultimately we need to be healthy. Thank you. Thanks a lot.
Thank you so much, everybody, for your patience.
So I think coming to the end of the session, my profound thanks to Professor Dr. Leslie, Dr. Manjari and Dr. Kritika Rao for throwing such a beautiful insight on this topic. I think the links and the recorded YouTube will be shared with the post test also from Vinila. Thank you, Vinila. And the next session is on 16 September at the same time. And the topic would be palliative care for adolescents and diversion activities. This will be taken by Dr. Veronique and Ms. Anuradha. So we'll meet up again next week at same time. So till then, thank you and take care.